Good morning, good afternoon, everyone. We're going to wait a minute or two while we see if other people join the call. This is the Harvard Emory sponsored antiretroviral for prevention webinar for the Centers for AIDS Research around the country. We'll introduce our speaker, and if you can please post questions in the chat. Patrick Sullivan, my co-host, will facilitate that after Professor Jean-Michel Molina makes his remarks. I see that a few people are still joining, so we'll wait just another minute. I hope everybody had a pleasant Thanksgiving holiday. Maybe just a few more seconds. Still see folks are joining. Okay. Well, thanks everybody for joining this antiretroviral for prevention webinar series as part of the National Centers for AIDS Research. My co-host is Dr. Patrick Sullivan of Emory University. We're really pleased and honored today to have with us Professor Jean-Michel Molina. He's a professor of infectious diseases at the University of Paris-Cité and head of the infectious disease department at the Saint-Louis and La Lavoisière hospitals in Paris, France. His primary clinical research has been on really all aspects of HIV prevention. He's led trials of therapeutics, but in recent years, he's really done groundbreaking work with a focus on HIV prevention, particularly looking at the issue of on-demand or episodic PrEP. Clinically, he is following a cohort of more than 3,500 people on PrEP and has had an ANRS funded study to try to use strategies around Paris implement control of HIV. He's also looked at the issues of oxypep and antibiotic prophylaxis, as well as gonococcal vaccines. So without further ado, we'll turn it over to Dr. Molina. Please, as a reminder, please put your questions in the chat. Dr. Sullivan will be facilitating that at the end of Dr. Molina's remarks. Thank you again, Jean-Michel.
You're very welcome, Ken, and I would like to thank you very much for inviting me to this webinar. It's a great honor for me, and I would like to thank also Patrick Sullivan for this kind invitation. So good morning, everyone. I'm going to share my screen now. I hope you're going to see the slides. And I've been asked to review the work we've done over the years on the use of on-demand oral PrEP. And, you know, my title is a bit provocative. Is it only for French GBMSM? And I'm going to try to show you that indeed it is not. So these are my disclosures. And, you know, I thought it was interesting to get a bit of history of how did we get there. And we started to be interested in assessing on-demand PrEP with oral TDF-FTC back to 2008, when I was asking to give a talk in Thailand in a French site where we do a lot of research on prevention of HIV and hepatitis B. And at that time, we realized that all ongoing PrEP trials sponsored by the US were using a daily regimen of TDF-FTC, whether it was the IPREX, the VOICE, Partners PrEP, or FemPrEP studies. And we had doubts about real adherence to a daily pill regimen in GBMSM or in other population who are not infected with HIV, and we weren't sure that you know, people would adhere to a daily regimen. So we thought of you know, another strategy to prevent HIV using an on-demand regimen based on events-driven PrEP. And we had a lot of discussions with the investigators of the daily PrEP trials, with Bob Grant in particular, but also our colleagues from the CDC, with their non-human primate models. And based on these discussion and these data, we design our on-demand PrEP regimen in the PrEP studies. And our expectation was to improve adherence and therefore expect a higher efficacy of this PrEP regimen. We thought also we needed to have a high level of confidence with the results, and that's why we designed a placebo-controlled randomized trial. But if you want to do that, we needed to wait for the results of the IPREX study because if the results from IPREX were very effective, then it would not be ethical to run a placebo-controlled study. And if the results from IPREX were very disappointing, then there was no reason to think about an on-demand regimen anymore. So we were, in a phase where we're waiting and expecting the results from the other PrEP trials before starting this study. And the reason why we wanted to test on-demand PrEP is we thought that this regimen would be more convenient for people to remember to take their pills. And we have also the lessons from the tenofovir gel, who had shown at that time some efficacy in the CAPRISA trial in South Africa, but was not effective when used daily in the VOICE study. We thought also on-demand PrEP clearly gives guidance on when to start, when to stop PrEP. And these are issues which are, I think, still relevant today. Indeed, using fewer pills would probably lead to a better safety of the regimen, improve its cost effectiveness, and potentially facilitate the diagnosis of PrEP failures and reduce the risk of selecting resistance. And we thought it could be, anyway, an alternative to daily PrEP in people willing to have another option. So these are the data generated by Gerardo Garcia Lerma in Walid Hainaine team at the CDC, where they tested in the sheep macaque model using rectal challenges different dosing regimen. You have them on the left, and we were, interested in the group 4, where we thought this would be, something convenient for humans to start PrEP 2 hours before exposure, and then another administration 22 hours later. And with this regimen, group 4, you could see here that the protection was not perfect. It was much better than in dotted red in the controls, and not that different from daily, but daily looked better. In the appendix of this paper, what was interesting is when they used the double dose in these macaque models of TDF-FTC in the macaques, then the efficacy was much higher. And you could see on the small graph that the only macaque who became infected was actually a macaque in which the plasma drug levels of tenofovir and FTC were really below the others. So we thought this is a regimen that could be quite effective. And we know that the PK of tenofovir and FTC is dose proportional. So using a double dose made sense. And in this study, the reduction in infection was 83%. So we were waiting for the results of IPREX. You remember IPREX was a randomized placebo-controlled study in uninfected MSM at high risk of HIV acquisition. And this was an events-driven trial. And the aim of the trial was to show that the efficacy was at least 30%. And for that, they needed to have an efficacy of at least 60%. And when we looked at the results, and I was invited to go by Bob to New York to see the results before they were publicly released. And you could see that the results showed a 44% relative reduction in the incidence of HIV. This was highly significant. But when you looked at the confidence interval of this reduction, the lower bound was 15. So it was actually lower than expected. And so there was, in that case, room for improvement. And following these results, we said, well, now we can launch our study because I think we could do potentially better to improve adherence with an on-demand regimen, because we thought 44% is probably not good enough for implementation in France. And it was also not so high so that the placebo-controlled study was still ethical. And indeed, one of the reasons was why the efficacy was not that high was because adherence to the daily regimen was not high. And in a subgroup of patients, they looked at plasma drug level, and they were detected only in 50% of them with a limit of detection of 10 nanogram per ml. So only 50% of the patient used daily PrEP in the study. So we started to work with the community, and we did visit all across France to explain what we were doing, how to recruit participants in the study. We were supported by the two big NGOs, ACT UP France and AIDS, to really design our study. And the study was named HyperGay, which means preventive intervention for and with gays. And the study was a simple design, randomized, placebo-controlled, TDF-FTC before and after sex or placebo pills. And the expectation was to have, well, the assumption, an HIV incidence in the population of 3%. We target a 50% reduction with on-demand PrEP, because in HyperX it was 44%. We thought we could, assess or aim to a higher reduction. And we need for that 64 events in 1,900 subjects. So this was the way we designed the on-demand regimen: 2 tablets at least 2 hours before. And this was based on the macaque models. And then for the after pills, the after sex pills, we said, well, if we ask people to take 2 pills at once, they may miss 1 pill. So we said, well, let's separate the second after pills to 2 different days. So if people miss 1 day, they may not miss the other day. And we want also to leave people enough time after the sexual relationship to take the after pill. So it was a 3rd pill 24 hours after the first intake, and a 4th pill 48 hours later. And this dosing regimen will really tells you exactly for people how to start, how to stop PrEP. And indeed, if you have a sexual intercourse after the 3rd pill, then you need 2 pills 24 hours apart after the last sexual intercourse. In the meantime, while the study was ongoing, there was a press release from our colleagues in the UK with their PROUD study, which was an open label trial, not a placebo-controlled study, where they looked at immediate oral PrEP daily to defer PrEP after 12 months. This was initially a behavioral study. Their primary endpoint was to look at time to accrual of the participants and retention. But during the course of the study, because they've seen a number of HIV infection, the DSMB eventually decided to stop the study because they thought it was unethical to continue, and because they said they had reached predefined, goals. So when we learned that, we asked our DSMB to interact with their DSMB and to see what should we do with our study. And so our DSMB looked at the data and decided to also stop the trial, our trial. And when they stopped the trial, we only had a mean follow-up of 12 months. We only had 400 people enrolled. But as you can see on the slide, we had a pretty high incidence of HIV in the placebo arm, which was 6.6%. And the incidence was even higher in Paris, 9%, a very high incidence in those MSM. And the incidence in the TDF-FTC arm was only less than 1%. And you could see that during the first 16 months of the study, there was not a single infection in the TDF-FTC arm. And the only 2 infections that were diagnosed were diagnosed in people who have discontinued PrEP because they were tired of being in the trial after a year and a half, and they thought they were no longer at risk. So I would say on treatment efficacy was 100%, but the effectiveness was 86% in the intent to treat analysis. So this was much higher than we expected, and the incidence was also much higher than we thought, and that explained why we were able to show these results with a limited number of participants. At the same time, when they presented their data at CROI, Sheena McCormack and her team showed the exact similar efficacy with daily PrEP in those men in the UK. So both studies were conducted in the same population at about the same time and found the same result whether you used an on-demand or a daily regimen. And I thought this was interesting. And actually, these data were presented head-to-head at CROI, and it was felt then, the doubt about HIV prevention were dispelled, because at that time there was, question around the negative findings from VOICE, from FemPrep, etc., and there was really interrogation about the future of oral PrEP. Following these data, the WHO recommended oral PrEP as an additional prevention choice, and that was the start of the approval also in France and in Europe as early as January of 2016. When we looked at the pill use in people using on-demand PrEP, using these graphs, you could see that the way people use PrEP was really on demand, in that very few people were consistent in the use of pills. But this is pill count. We know it's not perfect. But on average, people use a median of 15 pills per month in the study. So about 4 pills per week, which would cover one sexual event. But we want also to address the issue of people who may have less frequent sexual exposure. And in the post-hoc analysis, we looked at people we use fewer than 15 pills per month, but when they said they were using the pills, it was during sexual intercourse at each time. And we looked at this post-hoc analysis, and we found 6 infections in the placebo arm, none in the TDF-FTC arm. So again, a very high efficacy in people who said they had a median number of sexual intercourse of 5 per month, so about 1 per week, and their median number of pills per month was less than 10, so less than 3 pills per week. So these results, again, are supporting the efficacy of on-demand PrEP. So you may not need to be on a daily regimen to be protected by PrEP. But these were the results during the double-blind phase of the study. We then started an open-label phase where everyone could have access to oral PrEP, because oral PrEP was not approved at that time. And so in both arms, almost 95% of the individuals continued to be followed during in the study using open-label TDF-FTC. And we had, therefore, more than 500 years of follow-up, and you could see that the incidence during the open-label phase dropped from 0.1, 0.9 to 0.19. And so if you look at this incidence reduction versus placebo, you had a 97% relative reduction of HIV incidence during the open-label extension, with a median follow-up of nearly 2 years. And so I think these are the highest, one of the best results of reduction of HIV incidence with PrEP, maybe except the recent lenacapavir study in young women. We also looked at plasma drug levels in those individuals, and if you combine those, we had more than 40%, 40 nanograms, per ml. It was on average in 50% of the population. So in other words, we find if you only look at plasma drug level, about half of the participants had drugs detectable at the time they came to the visit. And in a small proportion, the the drug level was much lower, so that means that the drug intake was probably in the week, but not recently. We also look at DBS during the open label extension phase at the last visit, and the median TDF diphosphate concentration in the DBS was 517 femtomole per punch, so which corresponds to an estimated intake of 2 to 3 doses per week. And less than half of the participants had a tenofovir diphosphate level above 700 femtomole, which is associated with if you use a daily regimen, a full protection. So again, you have a wide range of tenofovir diphosphate concentration, which is in line with the on-demand regimen in those individuals. And indeed, in the open label extension of Hyprex, Bogrand and colleagues reported that when you have a DBS above 700 femtomole, then you probably take from 4 to 6 pills per day, and the incidence of HIV is almost zero. And if you are using 2 to 3 pills per week, you are in the range of 350 to 700 femtomole. But even with this dosing regimen, if we had used 2 to 3 doses per week in IPERGAY, the difference with Hyprex is that we have an 86% reduction of incidence as compared to 44% in Hyprex. So it's not only the number of pills, it's really the time at which you're taking the pills regarding your sexual exposure. We try to better assess what people were really doing when they took their pills. It was a challenge. So in a small number of participants, we conducted a 2-month study in which we used memcaps as well as SMS every day, text messages, to know when people had sex. You could see on the top panel that there was a very strong correlation between pill counts and the total bottle openings. And in the bottom graph, you see how we could analyze the data in terms of coverage of sex events. You have the mem openings in blue, and in black, you have the start of the sexual section and the end of sexual section. And then you could see when people used, perhaps sometimes they had no sexual exposure, and sometimes they kind of used the pills the way we recommended them to use the pills. Another way to look at the data was also to look in the study at a few participants who were daily users in that study, and the majority were on-demand users. And you could see that, of course, with daily users in blue, and if you look at the right box, in people at highest risk, those who had condom-less receptive anal sex, with daily users, it was 95% who were covered. With on-demand, it was only 82%, which had their condom-less receptive anal intercourse covered. We don't know whether it was with a regular partner, with an encounter in that study. It's important to look at these data when to put them in perspective with the results from another event-driven or on-demand or intermittent PrEP regimen in the HPTN 067 study, the ADAPT trial, which was conducted, you may remember that trial, in both women and men, MSM in New York and Bangkok, women in Cape Town. And in that trial, there was a randomization to 3 arms: daily TDF-FTC, time-driven TDF-FTC, 1 tablet 2 days per week, plus 1 post-exposure dose within 2 hours after sex, and 1 event-driven TDF-FTC, 1 tablet before sex, 1 post-exposure within 2 hours, which we thought was a bit difficult for people to take or to remember to take a post-exposure pill 2 hours after sex. And the primary objective of this study was to look at the coverage of sex events. And the definition was at least 1 pill in the 4 days before sex and 1 pill in the 24 hours after sex. So we are a bit more flexible because we wanted to assess when we say coverage within 48 hours after sex as well. And people were asked about their sexual activity in the past week. And what they found in Bangkok among MSM, when you look at complete coverage in the left-hand side, you see 85% with daily, but 74% with event-driven. And you could see that it was the post-exposure period that was missed most of the time. We had similar results in Harlem, in New York City, where you could see that the coverage, even with daily PrEP, was not perfect, 66%, 52% with on-demand, event-driven at that time. Interestingly, when you look at the study in terms of breakthrough infections, although the number were small, there were only 50 to 60 individuals per city, you could see that the number of infection was similar in those using daily PrEP or time-driven PrEP or event-driven PrEP. Of course, we cannot draw any conclusion from these data, but at least the event-driven PrEP regimen was not so worse, so bad, and even in women. And this is to keep in mind for the future of my talk. In order to collect more information about on-demand PrEP regimens, we thought we needed to do another study, and we started what we call the Prevenir study to prevent HIV infection among people at risk for HIV. We would start PrEP. It was not intended to be only for MSM, but you will see that we recruited 98% of the participants were MSM in the study. And people could choose whether they want to use a daily or an on-demand regimen, and we would follow them initially until May 2020, but the study was extended to actually May of next year, so we will get the final result next year. The aim would be to show how, in order when you increase the offer of PrEP, you could have an impact on the new infection in the Paris region. So, as I said, people enrolled in the study were mainly MSM, 98 to 99%. And those who selected to use on-demand, you could see that roughly half choose to start on a daily regimen, half on an on-demand regimen. And those choosing on-demand had fewer sexual partners in the prior 3 months. Over time, you could see that this proportion remained stable, even though, from one visit to another, roughly 10 to 15% switch from daily to on-demand or vice versa. Overall, 50% of the participants remain on an on-demand regimen and 50% on a mainly daily regimen during the first 18 months of the study. When we looked at the use of PrEP at the last sexual intercourse, clearly those using on-demand use PrEP in 82% of the cases versus 97% in those using daily PrEP. Most of the PrEP use were correct, and as expected, up to 18% of those in the on-demand arm didn't use PrEP at their last sexual intercourse, most likely in the questionnaire that we had because it was a sexual relationship with their regular partner. Overall, 20% of the participants still use condoms in that study. And when you look at the global HIV incidence with a mean follow-up of 22 months, it was very low, 0.1%, so 1 per 1,000 person use a follow-up. And the number of cases were evenly distributed between daily and on-demand, 3 in each case, in each group. So again, these data reinforce the fact that on-demand PrEP seemed to be as good as daily in those MSM. And according to TDF diphosphate concentration in DBS, again, the average use of pill was about 3 per week. We also looked at the impact on the on-demand PrEP regimen on the AUC of EGFR to see whether you could see a benefit in terms of EGFR. And indeed, we see a significant difference when you look at the on-demand curve in red versus the daily. There were some differences, they were small, but we use these differences in people. We have an increase in EGFR or a decrease, sorry, of EGFR with daily PrEP, or in complex cases, and we switch them to on-demand, and that sometimes can, you know, overcome this issue of increased creatinine plasma level. So these data were thought to be convincing enough by the WHO to implement in July of 2019 the 2-1-1 regimen in the guidelines, as well as the IAS USA guidelines, and it was started to be cited by the CDC guidelines. Cited, not recommended. So in summary, I think we have strong data showing high effectiveness of on-demand TDF-FTC among MSM. It provides an alternative to daily PrEP and expands PrEP option. It could potentially be interesting in those who have adherence issue with daily PrEP. It would be cost effective, obviously, and may improve safety. And I said, but I cannot prove that it may facilitate the diagnosis of breakthrough HIV and reduce the risk of emergence if you think that people, you know, develop resistant mutation when they are infected at baseline, start PrEP on a daily regimen, then you are going to see resistance emerging. So another important question is, what about on-demand PrEP for women? Is this regimen suitable only for MSM, which I don't think it is, but we don't have any data for women. So however, when you think about the way PrEP works, if you think that's the level of drugs in plasma that is more important, then we know there are no differences in the PK of TDF-FTC in plasma or PBMC in men versus women. Recently, the BASH-BIVA guidelines in the UK recommended that for men and women, you can start with a double dose 2 to 24 hours before risk because, and I'll show you the data, this achieves very high concentration, not only in blood, but also in tissues within 2 hours. So the onset of protection with oral TDF-FTC, if you use a double dose, is probably as short as 2 hours. So there's no reason to wait and to for a week, for example, in both men and women to say you're protected. And the BASH-BIVA guidelines went a step further, recommending that after an exposure, you could stop PrEP 7 days later. And therefore, they now recommend an on-demand PrEP regimen in women, starting with 2 pills and then continuing a daily regimen for 7 days. So that means women as well, even though we don't have data from clinical trials, but based on PK/PD studies, could potentially also use an on-demand oral PrEP regimen, pending more simpler options. And these are based on data generated by Angela Kashuba's team presented on this slide, where they enroll 49 women who receive either TDF alone or TDF plus FTC, and they sample blood, rectal, cervical, and vaginal tissues over 48 hours. And then they use a PK/PD model to look at plasma and also tissue concentration of tenofovir diphosphate, FTC triphosphate, and the competing endogenous nucleotides. And they also use a CD4 T cell model to try to identify 90% effective concentration ratio of the diphosphate or triphosphate for protection against HIV. And they use the Alpha-Gay 2-1-1 dosing regimen in their models, which are shown on these slides. So on the top panel, you have colorectal tissue. And you could see that when the first dose is given at time 0, you have protection at the time of coitus. Actually, the dose was given 2 hours before dose 0. 0 is the time of sexual exposure, if you wish. And 81% of the women had reached this EC90 concentration in the rectal tissue 2 hours later, and it was 98% 24 hours later. And you can see that the concentration, when you look at TDF-FTC in the dotted line, are maintained for 240 hours. On the bottom panel, it's in the female genital tract. And here you could see also that at the time of coitus, it's 98% of the women who reach a very high concentration at 2 hours. But with TDF-FTC, because it's probably FTC which can be distributed faster to the genital tract, then you had this high concentration, but it lasts only for 120 hours. So there is a 120 hours difference between the female genital tract and the rectal tissue, which is actually which makes 5 days. And that's why for women, we would say the post-exposure pills would be for 7 days instead of 2 days. But the one of the questions we have is, this is quite complex regimen. Can we do better? Can we simplify the on-demand PrEP regimen? And for that, we thought about using TAF-FTC for that. We know that TAF-FTC and Ken was the PI of this DISCOVER study, a double-blind placebo-controlled study comparing FTAF to TDF-FTC. That study was not probably powered enough to show a superiority of TAF-FTC versus TDF-FTC, but it was at least non-inferior, and there was a trend towards a lower incidence with TAF-FTC in this trial. And indeed, when you look at tenofovir diphosphate level, they were much higher than with tenofovir FTC. And when you look at the PK in healthy volunteers, that's interesting because the PK, so you have in blue TAF, in gray TDF, you can see that within 2 hours, and here you look at not only the plasma, because we know that the Cmax is at 2 hours with both TDF and TAF, but look at the TDF diphosphate concentration at 2 hours with TAF, it's above 100 femtomole, whereas with TDF, it's only in the range of 10 femtomoles. And we think that you need at least 16 femtomole, maybe 40 femtomole to be protected. So that's interesting to see that with TAF, you can reach very quickly very high concentration in PBMCs. And when you stop treatment, the models shows that the concentration decrease within 10 days with TDF-FTC, but it takes 16 days with TAF-FTC to have concentration below the threshold of 40 femtomoles. So that's interesting. And we thought these data, plus the non-human primate data with TAF-FTC for PrEP using rectal challenges once a week, you can see that with placebo, you infect all animals after a number of challenges. But in the green dotted line, after 15 weeks, there was no infections. So we thought, there is interest of this TAF-FTC option for MSM to prevent rectal challenges. And indeed, we started a trial called SimPrep, or Simplified PrEP, where we are randomizing. The trial started a few months ago in France and Thailand, and we randomized people to either the 2-1-1 regimen with TDF-FTC or the 1-1 regimen with FTAF. And we want to look at the incidence of HIV in those two arms as compared to a background HIV incidence rate. So we will enroll 500 participants and follow them for 2 years, and we hope our assumptions are not going to be too wrong. So to complete my talk, I think it's also, of course, important to know whether or not MSM are interested in on-demand PrEP, and not only MSM in France, but MSM in the US. So I'm going to show you some of the surveys that were done, this one in 2016, assessing among young MSM recruited by Facebook in the US in 2015, according to their type of sexual exposure, what would they prefer? On-demand PrEP, daily PrEP, injectable PrEP, gels, etc. And you could see that on-demand PrEP ranked first in that survey for all types of exposure. And then I used the study that you published recently with Patrick Sullivan and his group among MSM in this American Men's Internet Survey. I thought that was interesting data showing that among those not using PrEP in the last 12 months, 54% reported willingness to start at least one options, and on-demand PrEP was quite also interesting for those men, although a pretty high proportion also wanted to use multiple options. And more interesting enough, in those already on daily PrEP, 58% were interested in switching to another dosing regimen, and still 1/3 of those willing to switch were interested to switch to on-demand PrEP. So I think there is an increased interest of using on-demand PrEP in the US and also in Australia. This is a study published last week in the GIS, so Ken knows very well that study in this journal. And these were data from the National Behavioral Surveillance Survey in Australia, where they looked at every year what's the proportion of people using daily or event-driven PrEP. Event-driven PrEP was introduced in the Australian guidelines in 2019, and you can see that over time there was first an increase in PrEP use, because the overall PrEP use increased in these MSM from 27.6% in 2019 to 42% in 2023. So that's a pretty high proportion of MSM using PrEP. And among those using PrEP, the use of event-driven PrEP increased from 7.6% in 2019 to nearly 28% in 2023. So I think this is a trend that people will follow, and we may see in the future more use of on-demand PrEP. So in conclusion, I think, and I hope I showed you convincing data on the effectiveness and safety of on-demand PrEP with oral TDF-FTC among MSM. I think the interest of this regimen, which can be combined with a daily regimen, because if people have sex on multiple consecutive days, they can combine the on-demand and the daily. And the interest of the on-demand is it gives you really good information about the onset of protection and the way to stop safely PrEP when you're not exposed. I think it should be used, and it has to be used in other population, because again, I think probably, and that can be a matter of debate, should we rely on tissue concentration or blood concentration to assess the effectiveness of the PrEP regimen? Well, I think blood concentration probably matters most, even though tissue concentration may also have a role. I think there is growing interest by users of on-demand PrEP. In conclusion, I think it's a valid alternative to daily PrEP. So before I close, big thank to my team, because this is a teamwork. And we work with a number of support from a number of institutions, and in France in particular from the French Agency for AIDS Research. If you want to come to Paris next October, I welcome you to attend the European Conference, the European AIDS Conference in Paris from 15 to 18 of October. It's open to everyone, of course. And I think I'll stop here, and thank you for your attention.
Thank you so much, Dr. Molina, for your presentation, which was comprehensive, and I hope will stir up a good discussion in the time that we have left. So I'd like to encourage people. I have a few questions to start us off with, but I'd like to encourage folks either to put up your Zoom hand, or to post a question in the chat, which I can pass on, and we'll get Dr. Molina some questions. So I am going to start out just by asking about, I mean, you've given us a really comprehensive review of the original the conception and the original science, and a number of branching pathways here. But what do you think will be the next game changer for PrEP? Is it more dosing regimens? Is it different agents? Is it implementation strategies? What do you think is the next big question that will take us to another level?
Well, I think that's important. I think the next level would be to make PrEP easy to access to everyone, having a a safe regimen, very safe regimen. I mean, safety, it's really key for PrEP. Safe regimen, effective regimen. We want to have a regimen that are almost 100% effective. We probably cannot accept less than that. And we need to have multiple options. And some people may prefer injections, other pills, pills, on demand, pills daily, pills once a month. We'll see. But I think eventually, and this is very similar to the contraception field, we need multiple options, and people will use what that would suit them best. And but the idea would be to make them as easy, accessible to condoms, and as safe as condoms.
So thanks for that. It really feels like there is a substantial implementation, component to really the priorities that you've laid out. And that's probably also going to be somewhat specific to different countries, and to rural and urban settings. And so I'm just thinking for our colleagues who are on the call, especially earlier career colleagues, just thinking about what that next generation of questions will be to get the highest population impact. And so it's great to see all the different options coming in the pipeline, but I agree with you that we still have a lot of ground to gain in implementation and preference, and how we get these medications and the intervention out. I see Ken popped on. Ken, did you want to ask a question, or
Sure.
do you have another comment?
It was fantastic talk, Jean-Michel. I'd like you to comment about on-demand PrEP for transgender individuals. There have been concerns about some of the pharmacologic interactions of gender-affirming hormones. So I'd like you to comment on that, please.
Sure. So there are a few, a small number of PK drug-drug interactions where there was a small decline in the PK. I think it's not such a big concern, but we may need to have another look and do a proper and larger PK PD studies. And again, so we have limited data, I have to admit, using on-demand PrEP in transgender individuals, especially those using gender-affirming hormones. And this is maybe a missing. There are missing data. Well, I think the data we have are not definitive, and we probably need to explore that in more details in this population.
In the meantime, in France, are the guidelines permissive, encouraging for at-risk transgender individuals to use on-demand effective PrEP?
Yes, they are. They could.
Okay. And one other quick question. At what point would you recommend PEP if somebody's on an on-demand regimen and then they don't take the next dose and it's been X number of days? So when would you say you better use PEP instead of relying on demand because it's been too long? Right.
So what we used to say now for PEP is that probably, but this is not based on good data, but we say probably what matters most is the time at which you start PEP. You should start PEP as soon as possible. So don't waste your time in the emergency room trying to have access to a triple drug regimen. You already have your pills. You have your TDF-FTC pills. So start your TDF-FTC pills as soon as possible, and then call us and we'll see whether you need a triple regimen or not. And when do you need to do that? Well, if you do not follow the regimen, and in particular, if you missed the post-exposure pills, which sometimes happen. We tend to, in the studies we've done, we define, incomplete coverage if people use, only one pill before, one pill after. This would be incomplete coverage. But we think this is good enough to not request a PEP regimen, especially in those who have used, we used on demand regularly, probably. Then you have a way of trying to discuss on a case-to-case basis if people, is it the first time in month they are starting to use PrEP again, or if they use it once a week, for example. It's probably not the same answer that you could give. Clearly, those who are not using pre-exposure pills or post-exposure pills will need to use PEP. If you use at least one pill before, one pill after, we think that's probably good enough, although, the safe recommendation would be for anyone who is not following the 2-1-1 regimen should start a PEP regimen. So that would be the short answer. The more complex answer is then, well, we look at what people did in the week before, the months before, and what exactly. So it is difficult to give a very short answer, or as a short answer, those not using the 2-1-1 should start a PEP regimen.
Thank you. Over to you, Patrick.
Yeah, thanks, Ken. We have a question from one of the attendees, and so we can open up the mic for Wigilia Mikomangwa. Please go ahead with your question.
Okay, thank you very much, Jean. That was very informative. My name is Wigilia Mikomangwa, and I'm a PhD student from Tanzania. And I'm doing my research on PrEP use among female sex workers. And I just wanted to highlight a few, and indeed, your presentation has been very informative, especially from just to share a bit on the experience with regard to PrEP use in Tanzania. The only regimen that we have is daily PrEP. Although we have been, the long injectables have been approved, but is yet to be rolled out in the HIV prevention program. So one of the experience that I did see during my research with regard to PrEP use was on the disagreement with regard to the sexual behavior vis-a-vis the PrEP use. I've already published one paper whereby there was a very high level of discontent between the sexual practice, especially those who were doing condomless sex, vis-a-vis the PrEP use. As I've just seen that on your presentation, you said very well that the average use was 3 pills per week. But I feel like most, especially because my research was on female sex workers, they do not even adhere to that level of adherence to use all those PrEP doses as required. And during the interviews, most of them felt like they cannot use it daily, like they are tired of using it daily. And most of them, even those who used, they just used it when they felt like they want to use it. For example, they are meeting their sexual clients, that's all. So what's your comment on that, since you have already highlighted very pretty well on the effectiveness and safety of on-demand, although with limited data on women. So I'm not quite sure of the characteristics of those women who were involved on those research. Were they female sex workers, or what characteristics? Since I see like most of people do not live like using all those periods, even those the 7 days post-exposure feel like still might be a bit challenging. Right. What's your comment on that?
Well, thank you for your question. I think this is a field that has to be explored in more details, the field of on-demand PrEP in women. We tried for years to do a study assessing on-demand PrEP in women, and we couldn't succeed in finding the right population and the right design. So we failed so far to have a study on-demand women funded at this point. Again, I think it would be, we don't have clinical data, as I told you, with on-demand PrEP in women, we have only PK data and data in men, that some of them could be extrapolated to men, especially the blood PK. So I would say in your case, if those women do not adhere to a daily regimen, it would be best for them to try at least to use the pills at the right time, according to the data we have, starting PrEP before their sexual exposure and continue PrEP for as much as they can, up to 7 days potentially after the sexual exposure. That would be better to not to take any PrEP at all, or take just one pill like that. So at least you can tell those women, if they cannot take a daily PrEP regimen pending the availability of injectable PrEP, that it is potentially an option for which we don't have a lot of data at this point, but we have some reason to think that it would confer some level of protection. We cannot be more definitive about that. And I think that would be interesting to know whether or not women would be interested to use PrEP in that way or not. Is it feasible? And can we collect information, in particular in those who were not willing to use daily PrEP, if they don't want to use condoms? So I think this is a field that needs to be explored.
Wonderful. Dr. Jean-Michel Molina, thank you so much for the presentation today, and thanks to our participants for the questions. I'd like to call everybody's attention to Alberto's announcement in the chat that the recording from today's presentation will be available on the Harvard CFAR YouTube channel and the Emory CFAR website. Our next AFP session is scheduled for February 3rd. And we're actually going to focus on PrEP in transgender populations with Drs. Sari Reisner and Tanya Poteet. So we'll look forward to seeing you all then. Ken, any other closing comments?
No, thank you, Jean-Michel, for a fabulous presentation. Very stimulating. Always learn something new from you. So thank you.
Thank you very much, Ken and Patrick, for your invitation, and thank you for the questions. Bye-bye.
Bye-bye.
Sure.
Thank you.
Bye bye. Thank you.